welcome everyone to the experienced patient caregiver session on extending the life of your child's kidneys. Once we get started, I'm going to, feel free to ask any questions. Use the Q&A function in your Zoom toolbar if you're just now joining us. It's my pleasure to introduce Dr. Michele Rheault, a pediatric nephrologist from the University of Minnesota. You have met her in the nephrology panel a little bit earlier, but I'm going to tell you, she completed her pediatric nephrology fellowship at the University of Minnesota in 2006, followed by a research fellowship at Mount Sinai School of Medicine in New York City. She joined the faculty of the University of Minnesota in 2008 and is currently the director of the Division of Pediatric Nephrology and the medical director of the Pediatric Dialysis Unit. She's on the steering committee of the Pediatric Nephrology Research Consortium, a clinical research network that aims to facilitate collaboration in pediatric nephrology. Her clinical and research interests include Alport syndrome and other genetic kidney diseases, pediatric glomerular disease, and pediatric end-stage kidney disease. So thank you, Dr. Rheault, and I'm going to let you go ahead. You can start your slideshow if you'd like to do that.
All right, are you able to see my slides now?
Yes, it appears that you are still you're not in the presentation mode, if that makes sense.
Oh, okay, I can see the presentation mode, so I'm not sure.
Do you want to? Oh, you know what? Yep, go to slideshow. I see your cursor moving around.
Mm-hmm.
And then from beginning, that would be great.
How's that? Because it looks like it goes to presentation mode for me.
Okay, so I'm wondering if do you have two screens?
Nope, I just have one.
Okay.
Technical difficulties.
I know.
But worst case, I can just do it this way.
That's fine. That's great. Thanks so much.
Okay, so hopefully that will work out okay. So I'm Michele Rheault from University of Minnesota, and I must say that this is a very challenging, this was a very challenging talk to put together, because I know each of you are on a different journey with your child's nephrotic syndrome, and some of you are going to know everything that I tell you, and some of you, this may be relatively new. So if what I'm hoping is that you can find one thing today that you didn't know before that's useful in the care of your child's nephrotic syndrome. So some of the things we're going to go over today, we're going to talk a little bit about the kidney and about podocyte function. So podocytes are the cells in the kidney that help to maintain that filtration barrier that keeps protein in and keeps it out of the urine. We're going to talk about decisions to biopsy. When should you biopsy? Talk about some of the current treatment options that are out there and how to think about you trying those, and then some future treatment options in clinical trials and some of the decisions about when to start a clinical trial. So each kidney, we have two kidneys, and each kidney is made up of 1 million nephrons. So each of these nephrons, blood goes in the nephron. There's this ball of capillaries called the glomerulus. And in that ball of capillaries, blood is filtered across those capillaries into these tubules. And in the tubule, the urine is fine-tuned. So some things are reabsorbed, water is reabsorbed, until finally you end up with the urine that comes out. And this happens 1 million times over in each of your kidneys. What these glomeruli look like in kind of a cartoon depiction here is we see the blood going in, goes through all of these capillaries in cross section, and then the blood goes back out. When you look at it at a kidney biopsy, if you've ever had a chance to see the images from your child's kidney biopsy, we see it's a pretty similar picture. So we see these round structures within the kidney, and inside we see these tiny little capillaries where the blood is going through. And then this is just a nice image of what those capillaries look like in 3D. So you can really see it just looks like this little ball of worms almost. It's a little ball of capillaries that are working to do that filtration. So On top of each of those capillaries, that's where the filtration happens. And we call this the glomerular filtration barrier. And this barrier is made up of 3 parts. So within the capillary is the endothelium. So that's just cells that line that capillary. Then there's the glomerular basement membrane, which is a fine mesh that is made up of different collagens. And that also is important in keeping proteins and other large molecules in the bloodstream. And then sitting on top of that is this podocyte. And the podocyte is really one of the most important cells within the kidney. I may be biased, but I think it's one of the most important cells in the kidney. And each of these podocytes has different foot processes, so little extensions that go out onto that glomerular basement membrane to cover up the whole thing. And in between these foot processes are what are called slit diaphragms, or noted SD here. And that slit diaphragm are proteins that really create a very tight junction that doesn't allow for proteins or albumin to get through it. And this structure is very important for maintaining that normal kidney filtration. So when this gets disrupted for any way, then we start to see protein leaking out into the urine. If we look at this on a scanning electron microscope, so if you multiply the kidney by 10,000, then we can actually see what this really looks like in the kidney. So these cells on the bottom, this is the endothelium. Then these dark and light stripes, that's the glomerular basement membrane. And then we can see these podocyte foot processes sitting on top of this membrane. And you can even see that little slit diaphragm, that little line that's there connecting these foot processes. And that's what it should look like. And I think I just really love this picture because it shows so well how complicated these structures are. So this is the cell body of the podocyte, and they have these major processes that go out. And then they have these foot processes that extend out, and they interdigitate with the foot processes from the neighboring podocyte. So they develop just this really, really complicated structure where these foot processes are right next to each other and connected by the slit diaphragms. And this is necessary for filtration. So looking at it, it's not too hard to imagine that it's pretty easy for something to go wrong there and cause nephrotic syndrome. So this, again, is what the glomerular basement membrane should look like, and the podocyte foot processes sitting on top of it. So this is a kind of a normal, healthy kidney. And the kidney here on the bottom, this is what it looks like in nephrotic syndrome. So all of those foot processes are lost. So on top of the basement membrane, there's none of that foot process structure. It's really just a flattened kind of mass of cells on top of the glomerular basement membrane. So that structure is completely lost. And if you like to see things more in 3D, which I do, you can see here on the top, these foot processes look very normal. So they're coming together and are formed nice and close together. Then when nephrotic syndrome starts to happen, those foot processes start to pull back on each other until finally what we're left with is really just flattened cells. There's none of that foot process structure there anymore at all. And this is what it looks like in the nephrotic state. So really changing from this structure to this structure. And we know in animal models that this change can happen kind of just like that. It can happen over 45 minutes, but this change back from this this flattened state to the normal foot processes can also happen very quickly. So there's very tight control of these foot processes and their structure. And these are just some of the proteins that are involved in that structure. So there is a scaffold, just like you would see a scaffold in construction, that sits inside each of these cells. That's really important for maintaining the structure of those foot processes. And there are a lot of proteins that are involved in making sure that stays normal. So if any of those proteins have a mutation or are not being regulated correctly, then we can see that structure start to break down. So one of the most important ones is this, or one of the most well-known, the first identified, is this protein here in the middle called nephrin. And nephrin makes up that slit diaphragm. It's really the proteins that make up that line, that filtration slit between those podocyte foot processes. And if you don't have nephrin, if you have a mutation in nephrin, you have congenital nephrotic syndrome. So you're born with nephrotic syndrome. And these patients are very severely affected. Some of the more common proteins that can cause nephrotic syndrome is this podocin gene. So this podocin protein is a connector protein that connects that nephrin to the slit diaphragm in the middle, to the cytoskeleton, or to that scaffold in the middle of the cell that holds the foot process in place. And if podocin has a mutation, then children often develop nephrotic syndrome and FSGS in childhood, although there's a spectrum. Some are early in childhood, some are later on in childhood. And there's probably over 70 different proteins now that can cause nephrotic syndrome, and most of them are proteins that are involved in the podocyte. So one of the big questions that people come to when their child has a diagnosis of nephrotic syndrome is, when should we do a biopsy? There was a really large study done in the 1970s where every child with nephrotic syndrome who walked in the door got a kidney biopsy. And there were over 500 children in that study in the US and around the world. And what they found is that younger kids, so the kids under about 12, were very, very likely to have minimal change disease. So doing a biopsy in those kids didn't seem to be particularly helpful in making a diagnosis or deciding how to treat them. However, the older kids, the kids over the age of 12, were more likely to have something else. So maybe they would have FSGS or membranous nephropathy or something else. So those are the patients where a biopsy first was really important. But in the most part, for those younger kids, we don't necessarily biopsy right away. But we do biopsy if they don't respond to steroids, if they don't go into remission with steroids, or we biopsy if we're starting to think about using other immune suppressing medicines, if we really need to know what medication to treat. So we think about using a kidney biopsy or doing a kidney biopsy to either make a diagnosis if we're not sure what's causing the nephrotic syndrome, if we're trying to make management or treatment decisions, or to provide some prognostic or future information to help us understand what's going to happen to this kidney and this patient in the future. The biopsy can be useful for that. So one of the things people worry about is the risks of kidney biopsy, and the risks are quite low. These are usually very safe procedures. So this is a study that was done by Chuck Varnell at Cincinnati Children's Hospital, and they looked at all of the studies that have ever been done on kids having kidney biopsies, and it was 23 studies, over 4,000 patients and over 5,000 biopsies that they looked at. And the complications that they found were there was about anywhere between an 11 and 18% risk of a hematoma, which is just a little bit of blood that collects around the kidney. These generally go away on their own. They can cause a little bit of soreness and pain around the kidney, but usually those are tolerated reasonably well. Almost 1% risk of a blood transfusion, either because of blood lost in the hematoma or blood in the urine after the kidney biopsy, and about a 0.7% need for intervention due to a complication. So patient who maybe had to go back to the operating room to have bleeding stopped in the kidney, after the procedure. So biopsies are not without risk. So that's one of the reasons we don't do them on everybody right away. But we do them if we really think that they're going to be useful in helping us decide next steps. And some of the things that you may find on biopsy for patients with minimal or with nephrotic syndrome, you may see minimal change disease. And what this means is that the biopsy, the kidney really looks pretty normal on biopsy. And it's only when you magnify that 10,000 times, those electron microscopy images that we looked at before, where you can see that flattening of the foot processes, or that what we call foot process effacement. On patients with FSGS, we start to see the scarring. And this pink area here within this glomerulus, that's the scarring that we can see. So you can see each of these capillaries, these little loops, are all capillaries that are open, blood's flowing through them, they're filtering. And then this dark pink area, that's the area of scar. So all of those capillaries have been scarred over. And we call this focal because not every glomerulus in the kidney looks like this. It may be only one here or there. We call it segmental because only part of the glomerulus is affected. So it's not the whole glomerulus, it's only part of it. It's just the segment. And then the sclerosis is the easy part. That's the scar part. So focal, segmental, glomerulosclerosis. And one of the things that I think is even more important than the FSGS is an idea of how much interstitial fibrosis is present in the kidney. So interstitial fibrosis means permanent scarring. So this is area in the kidney that's between the glomeruli that has permanent scarring. And the more permanent scarring you have, the worse off your kidney is long term. And this is a special stain that's done on a kidney biopsy that can look for interstitial fibrosis, where any part of the kidney that's scarred shows up blue. So you can see that this kidney has quite a lot of scarring, quite a lot of blue in that biopsy. And you can see there are a number of glomeruli. Each one of these round structures here is a glomerulus. This glomerulus is probably in pretty good shape. Whereas a glomerulus like this, there's a lot of blue, a lot of that scar in that glomerulus. So that glomerulus is not quite working very well. And if your child has a kidney biopsy, it's important to know, how much interstitial fibrosis is there, because more interstitial fibrosis is bad. And this is a study done from Neptune. So Neptune is a cohort study where patients are enrolled at the time of their kidney biopsy with nephrotic syndrome and then followed over time. So they have information from the kidney biopsy, and then they know what happens to these patients long term. So patients who had 0 to 5% interstitial fibrosis, or even 5 to 25% interstitial fibrosis, they're represented by these two lines on the top. And on the y-axis here is the survival probability. And they're talking about kidney survival, not patient survival, just kidney survival. And what they found is that if you have between 0 and 25% fibrosis in your kidney, your outcome at about 2 years was pretty good, kind of 85% likelihood that your kidney is going to be doing well in 2 years. Now, if you go up to 25 to 50% interstitial fibrosis, now we start to see that kidney doing a little bit worse. So by the time you get out to 2 years, it's really only about 70% likelihood that your kidney will have survived that 2 years. And if you get up to 50% interstitial fibrosis, then your kidney is really not likely going to be doing well. More like a 30% chance that your kidney will survive that 2 years. So understanding the interstitial fibrosis that's in each kidney biopsy is really important to help understand how likely is this to get worse over time. And we often get so caught up in, like, what is the diagnosis? Is it FSGS or is it minimal change disease, that we forget to look at some of these other markers on the biopsy that really can be important to telling us what's going to happen. So once the biopsy has been obtained, the next question that we come to is, should I get genetic testing, or should my child get genetic testing? And the reasons to do genetic testing, there's a number of reasons. And one of the main ones is that some of the genetic causes of nephrotic syndrome may not respond to immune suppression. So if you have a mutation in that podosin gene, for example, that's that connector protein from the slit diaphragm to the cytoskeleton of the podocyte, you can give all the immune suppression you want, and it's not going to fix that problem. So treating patients with immune suppression, you can skip that and avoid that unnecessary treatment, and can really work on focusing on treatments like ACE inhibition to try to reduce the protein as much as possible. You can also identify potential treatment. So some of the mutations that can cause FSGS, for example, may respond to coenzyme Q10 supplementation. So a relatively simple supplement to help with mitochondrial function can really improve the proteinuria for patients with those very rare specific mutations. So knowing a mutation can sometimes help point to different treatments. And then one reason for genetic testing that I personally think is really important is that it answers the why question. When children develop nephrotic syndrome, families ask, why did this happen to my child? Why is this happening to them? There's often a lot of guilt. Is it something I did? Is it something I fed them? Is it, something in the environment? And often, that is not the case. It's just, that's what they were born with. And there's nothing we could have really have done about it. So knowing that is important. And it also helps to recognize if others in the family may be at risk. Some of these diseases, if you catch them early, they're easier to treat than if you catch them kind of at the very end. So it can be helpful. And then knowing the genetic testing results can help predict the risk of recurrent disease after kidney transplant if you get there. So these disorders, unfortunately, can come back after kidney transplant in a number of patients, but in most of the genetic conditions are not expected to come back after transplant. So if you know you have a genetic mutation, it's very unlikely that the disease will come back after transplant. So if you do genetic testing, how likely is it that you're going to find something? And it turns out that the younger you are, the more likely it is we're going to find a reason or find a positive result. So children in the first year of life who develop nephrotic syndrome, there's a full 60% chance that we're going to identify a reason for that nephrotic syndrome. So that's a really rare disease. By the time you get to about 1 to 5, years of age, if you have nephrotic syndrome in that age range, it's more like a 25 to 30% chance of us finding something. And then by the time you get to older teenagers, or teenagers, I guess, in general, it's more like a 10 to 15% chance of finding a cause. So, it's not great. This is going to change as we learn more and more genes. Every year, there are probably 5 or 10 new genes identified that cause FSGS and nephrotic syndrome. So eventually these numbers are going to rise, but at least right now, the causes that we can identify about 10% in teenagers, 10 to 15% in teenagers. And when we do that nephrotic syndrome, the type of mutation changes depending on their age. So as I mentioned, in these very youngest kids between the ages of 0 and 3 months who have nephrotic syndrome, they're more likely to have those mutations in nephrin, that slit diaphragm protein, or in podosin in green here. And then as you get a little bit older, this 1 to 6 range, podosin is the most likely gene that we'll identify. So there are a number of different genes, and they're at we see them at different likelihoods at different ages. So this helps your physician decide what type of genes to look for, and then also can help predict what we can use to treat. So when we're thinking about treatment of nephrotic syndrome, we have to think about what our treatment goals are. And from a kidney disease standpoint, there's 2 goals. One is we want remission. So we want that protein in the urine to be low or normal, or we want a partial remission. And the definition of this is different depending on which studies or which papers you read. But in general, we want to decrease the protein in the urine compared to where they started, ideally to a point where they're not having symptoms of edema that really drive kids crazy. So that's our goal for the kidney treatment, is remission and partial remission. And then our second goal is to do that, achieve remission or partial remission with a medication that does not cause side effects that are going to cause a problem. And the reason that even partial remissions are important is because that can lead to longer kidney survival. So this is another study from the NephCure group, and this looked at kidney survival here on the y-axis, and then the remission status going out to 48 months, so 4 years after diagnosis. So if you had a complete remission, your kidney survival was going to be great. You know, it looks like maybe there was one person who dropped off here. So kidney survival, great in patients who had complete remission. But even if you had a partial remission, you had a 90% chance of having good kidney survival out to 4 years. So that's pretty good for this disease, unfortunately. And then if you had no remission, however, then by the time you get to 4 years, you're closer to 50% chance of kidney survival. So even if you can get a partial remission, that can really improve that kidney's long-term outcome. So, you know, it's hard to be happy with a partial remission because we're really shooting for that, you know, dipstick negative for the protein, but even that partial remission can be helpful. So there are a lot of treatment options available. You all probably know these just as well as I do, but steroids, calcineurin inhibitors, mycophenolate, rituximab, lipophoresis. In clinical trials, there are a number of other drugs that are used to treat nephrotic syndrome, and we're just going to go over a couple of them here. But first, I wanted to talk about just some new data that recently came out of India. So this was a study looking at 117 children with infrequently relapsing nephrotic syndrome. So kids who have, you know, maybe 1 or 2 relapses a year. And they looked at our typical relapse treatment, which is to treat them with higher dose steroids until they go into remission, and then 4 weeks of every other day prednisolone. So many of you are probably familiar with that type of a regimen. That regimen was kind of dreamed up in the 1970s by a group of nephrologists who was doing a study, and that worked. It seemed to work to keep kids in remission, and that's just what we've been doing ever since, because it's that's what works for us. But nobody's really tested to see if can we cut that down. Can we use the low dose prednisolone for 2 weeks instead of 4 weeks? So this was a study that looked at that. And what we worry about is if we treat shorter, is that going to make kids have relapses more often? So is treating them for that full 4 weeks preventing those early relapses from happening? And it turns out not really. So the risk of kids developing frequent relapsing or steroid dependent state was about the same. We looked at the number of relapses per year. That was about the same. And then they looked at the cumulative dose of steroids. So kids who were treated with that shorter course had much less steroid exposure for that year, and we all know kind of what benefits that has. And then also they looked at the risk of respiratory infections, and although it wasn't significant, so the p-value wasn't less than 0.05, which is what we're looking for, there were more respiratory infections in patients who had more prednisone treatment. So not surprising, you're getting more immune suppression, you're getting more infections. So it may be that a shorter course of prednisolone may be good enough to prevent your relapses. And I would just talk to your physician if you're interested in trying a new regimen for your child with nephrotic syndrome. So tacrolimus is one of the calcineurin inhibitors. This is used for kids who are steroid sensitive, but they're having a lot of relapses, and we want something other than steroids to keep them in remission. Or patients who are steroid resistant. So it's really the first line treatment for kids who don't respond at first to steroids. The disadvantages are that it's time dosing. It has to be given twice a day at exactly the same time. So I don't know about your family, but my family is not always doing exactly the same thing at the same time every day. So this can be challenging. And because of that, it requires blood level monitoring. So you have to have blood tests to see what the level is in the body. The main side effects that we see are hypertension, high blood pressure, kidney scarring. So it seems crazy that this is a drug that we use to treat FSGS or kidney scarring, but it actually can cause kidney scarring as a side effect. So that can be a challenge. It can cause a little bit of a tremor, diabetes, and then like many of these drugs can increase the risk of infection. Rituximab, on the other hand, is an injection. This is used to treat steroid-sensitive nephrotic syndrome, patients who are relapsing frequently. I made a typo here. It can be tried in steroid-resistant disease, but it doesn't tend to work as well in patients who are steroid-resistant as those who are steroid-sensitive. Advantages are that it's given via an IV, so you get it once, and you don't have to think about it every day. Side effects primarily are infusion reactions, so an allergic reaction when you're getting the infusion. And then other problems we can see are infections. If you have hepatitis, it will be reactivated, which is very rare in children. It can decrease your immune globulins, your IgGs, so you can have a difficulty fighting off infections. And it also affects how you respond to vaccinations. So patients who have had rituximab in the past 6 months, who have gotten the COVID vaccine, have not been responding very well. They're not making antibodies against it. So we're recommending that people are waiting as long as they can after rituximab to get that vaccine. Mycophenolate or Cellcept is another pill that can be taken, also comes as a liquid, primarily for patients who are steroid sensitive, also taken orally twice a day. And the main side effects here are GI side effects. So it causes some nausea and diarrhea. Also can cause some low white blood cell counts and other cell counts, and again, infections. And then one of the newer treatments we have for patients with steroid-resistant FSGS is lipophoresis. So lipophoresis is it's a procedure where a machine is hooked up to your blood. So it requires a big IV catheter where your blood goes out, goes through the machine, and then goes back to you. And it removes cholesterol from the blood. And in some patients, this is able to put them in remission of their FSGS. And we really don't have any idea why this works. I will just be very honest. Some people believe that there's a protein that sticks to the cholesterol that we're removing along with the cholesterol. Others think maybe the cholesterol is having more of a primary effect in preventing the drugs from working. This is used about 1 to 3 times per week to start. And once you go into remission, then there's a maintenance phase of once a week. So the advantages are that, again, it's a treatment that you don't have to do every day, but the disadvantages are that you need that catheter. So how do these drugs, how well do they work? So I just want to run through a couple of different studies that looked at how well these drugs work, just so you have a rough idea. So this was a study of 48 children in Japan with steroid-responsive nephrotic syndrome who were treated with either rituximab in the blue line or placebo. So patients with relapsing nephrotic syndrome, not surprising, if they weren't treated with anything, most of them relapsed within between 150 and 200 days. So I think we all would expect that. If they were treated with rituximab, by 6 months, about 75% of them were still in remission. And by about a year, about 50% were still in remission. So this was one of the first studies back in 2014 that really showed that rituximab can work well in this population. What we are doing now, instead of waiting a full year, is that patients may get a second dose of rituximab at around this 6 to 9 months point to help keep them in remission. So in patients with steroid-responsive nephrotic syndrome, by about 6 months, 75% of kids are still in remission. This was another study that was done looking at mycophenolate and cyclosporin. Cyclosporin is an older version of tacrolimus. Most of us are using tacrolimus now, but the effects are similar. So it took 60 children and randomized them to either mycophenolate or the cyclosporin. And after a year, about 90% of the patients treated with cyclosporin were still in remission. And for MMF, about 60% of the patients treated with MMF were still in remission, or mycophenolate were still in remission. So cyclosporin does seem to be superior to mycophenolate, but again, the risk profile is different. So patients tend to tolerate mycophenolate a little bit better from a side effect standpoint. The cyclosporin or tacrolimus does require blood level monitoring. So it's not that every patient should be treated with cyclosporin and not with MMF, because cyclosporin is a little bit better here, but knowing that, you know, MMF is still pretty good. And then this was a direct study looking at rituximab versus tacrolimus. So this was 120 children, and they looked at tacrolimus versus rituximab. And very similar to tacrolimus, at about a year, there were about 65 to 70% of patients were in remission. And patients treated with rituximab, about 90% were in remission. So it seemed like rituximab did a little bit better than tacrolimus in patients with steroid-responsive nephrotic syndrome. So what we really want is kind of that marker again when they first present to us, so that we can predict who's going to do well on each drug. And then I just wanted to talk a little bit about the steroid-resistant nephrotic syndrome, because we don't really have a lot of clinical trial data in that population. So this was 131 children who were randomized to either tacrolimus or cyclophosphamide, which I haven't talked about because it's not a medication that we use very often anymore, just because of its side effect profile. But this is a useful study to see how tacrolimus does in patients with steroid-resistant nephrotic syndrome. And most often this is going to be FSGS. About 75% of patients will go into remission by 6 months of the disease, or 6 months of treatment. So if you're started on treatment with tacrolimus, you know, by 2 months, only about a quarter of patients are going to be in remission. So we treat a little bit longer. So don't be discouraged if you start a new therapy and within the first month or two, you're still not in remission. Give it time, and by 6 months, we have a much better response rate. So how can you decide among all of these therapies? So first, you just have to talk to your doctor. Make sure you understand what all of the options are, know what the risks are, and know what side effects and what is important for your child and for your lifestyle. If getting drug monitoring, you know, getting blood draws at 7:30 in the morning is really not going to work for you and your family, then maybe try one of the other drugs first, like Cellcept, if that would be a possibility. If your kid really doesn't like to take medicines and it's a fight twice a day to get them to take their medicines, maybe rituximab would be a good choice, because then they get the infusion and they don't have to think about it. So those are some of the things to think about. So if none of those medications are working, and unfortunately that happens more than we like, you can consider being treated in a clinical trial. So one of the things that's important to know about a clinical trial is that there are different parts of it, and you'll hear us talk about different phases. And it's important to know what phase of a trial you're being considered for, because that gives you a lot more information about this drug and what's going to be looked at. So the first phase of kind of clinical trials is what we call preclinical. So this is not in humans. These are treating mice or treating rats or other types of animals with the drug to get just some basic safety information and to see if it may work in the kidney. So once you have that information, then the drug goes to phase 1 trials. And in phase 1 trials, healthy adult volunteers are treated with the drug, and they're monitored for any side effects, and they're monitoring for dosing. So they may get a single dose of the drug, and then they monitor levels in the blood every 2 to 4 hours over the course of several days, just to see how the body's going to metabolize it. And this type of a study may be done in anywhere from 20 to 60 patients, healthy patients. It's different, a little bit different for every drug. And if things look okay in that phase 1 trial, there's no major safety concerns and people tolerate it pretty well, then the next step is a phase 2 study. And the phase 2 study is the first time where the drug is really looked at in the population that it's targeting. So if it's a drug for FSGS, this phase 2 study would be the first time a patient with FSGS might see it. And these are usually small studies just to get proof of concept. So we want to know, is the protein in the urine going to decrease when they're treated with this drug over a short period of time? And these may be anywhere from 8 weeks to 12 weeks, sometimes even up to a year. And then monitoring again for safety in that particular population that you're looking for. Most phase 2 studies don't include children because usually the drug hasn't been tested in adults. Rarely we'll have drugs that will start phase 2 in adults, and then if they get a certain number of patients that are enrolled that are doing quite well and don't have any safety problems, then they'll roll it out to children in the phase 2 part of the study. And then the phase 3 study is the most important study. This is the one where the treatment is given to larger groups of people. So this may, in FSGS, this may be 200, 300 people with FSGS. And now we're not just looking at, does it reduce the protein? We're looking at, does it protect the kidney function long term? So we want to know, is your creatinine staying normal? Is your GFR staying normal? Are your symptoms getting better? And then once drugs do well in this phase 3 part, then they move on to the approval stage with the FDA or other regulatory bodies. And then there's usually a phase 4 stage where there's long-term studies. And these phase 4 studies can also be pediatric studies. So if a drug is approved in adults, the FDA is required by law to test them in pediatrics. So each drug company has to submit a pediatric plan. So if the drug isn't approved for use in pediatrics at the time of approval in adults, then they have to go back and do pediatric studies. So all of these drugs will eventually be tested in children. It just may take a while. So one of the things that I've been pushing a lot of the pharma companies is to really include those pediatric patients as soon as they possibly can. So for example, in some of the phase 3 studies, allowing some of our older adolescents to participate, those 14 and above or 12 and above, can be really useful in getting more kids who really need new therapies access to drugs. And this is just one example of a phase 2 study that was done, that was reported out a couple of years ago. This is a clinical trial, a phase 2 study from Travere, and it's looking at a drug called sparsentan. And sparsentan is a new drug. It's not approved for use. It acts like an angiotensin receptor blocker, so like losartan or irbesartan, if you've been on any of those type of medicines, and an endothelin receptor blocker, so a medication that works on that endothelial lining of the glomerular filtration barrier. And that combination of drug has been shown to reduce protein in the urine. So they wanted to look at patients with FSGS to see if they would respond. So this was a study that was done in patients age 8 to 75, so a wide range, 109 patients, and only 8 weeks of treatment, so a relatively short period of time. And they looked at whether patients just had a reduction from their baseline protein in their urine. So the control group were patients treated with irbesartan, so just angiotensin receptor blocker, just a blood pressure medicine that reduces proteinuria. And they had about almost a 20% drop in their proteinuria. So those drugs are good. We know that they work, but they don't reduce your proteinuria all the way. Patients treated with the sparsentan, on the other hand, had about a 44% reduction in their proteinuria. So this can sometimes be the difference between having symptoms related to edema and not having symptoms related to edema. So this is potentially going to be a very useful drug. And there was a phase 3 study that was completed in patients also between the ages of 8 and 75. Those patients are currently undergoing their final follow-up stage, and we expect to have more results from this study within probably a year and a half to 2 years. So this is a really promising study that's coming. The other advantage of being in a study like this is that once you reach the end of this treatment, in many studies, so for example, this was only 8 weeks, But you are allowed then to stay on the treatment drug, or if you are on the placebo, you're allowed to switch to the treatment arm. So one of the advantages is that if you can kind of wait it out in this placebo period, then you will be offered the drug at the end of that trial. Not all trials are like that, but many are. So it's important to read the fine print and understand when this trial ends, if this drug isn't approved, will I still have access to it for participating in this study? So we already walked through earlier in the day today how to find a clinical trial that's nearby you. I would suggest first talking to your doctor to know if they have any trials nearby. And the other thing that you can do is go on the NephCure website and enter your zip code and find out if there's any trials near you. We have a number of patients who see us for clinical trials who are not treated in our center. So for example, I'm in Minneapolis. They may come here from Mayo. They may primarily be treated at Mayo or at other centers, and they come to the University of Minnesota because we have the trial available. And we work very closely with your primary nephrologist. We do not take over your care. We work with your nephrologist and really help you through the trial, and then have you see your primary nephrologist to continue on with your care. So, as you all know, nephrotic syndrome is complicated, and I just want to, give kudos to all of you for, spending a Sunday afternoon and learning everything you can about your child's disease. This is really how you're going to make progress. And the important things to really know are what does the biopsy look like if they've had a biopsy, and what does it mean for my child? Know if there are genetic reasons that your child has nephrotic syndrome, and know how your child's responded to medications in the past. I mentioned we have a relapse plan for each of our kids who have nephrotic syndrome in our group, and we work with parents to be able to come up with that plan, because every child's a little bit different. And know that your doctor wants to partner with you. We want to know that your child is getting the medications that they need, and that they're not having side effects. And if they are, we want to hear about it. And just really want to thank all of the sponsors for today. Many of these companies are working very hard to find treatments that we can use. And then just a reminder that there's a break at 2:40 to 2:50 where our expo hall is going to be open and you can connect with others. And then the regional roundtables are really important to connect with folks in your region. So please stick around for the regional roundtable. And I'm just going to go ahead and stop sharing and go back to start my video.
Yeah, thanks so much. That was great. Wonderful comments in the chat as well. We do have some questions.
Okay.
So Claudia is asking, should a kidney biopsy be able to confirm a diagnosis of minimal change disease, or only to confirm FSGS or other like scarring type of diseases, I guess?
Yep. Good question. So the biopsy, what we see on a biopsy is only a snapshot. So when we take a kidney biopsy, we know that there's 1 million glomeruli in each kidney, and we may see anywhere from 10 to 50 glomeruli on that biopsy that we do. So FSGS is, as we talked about, it's focal. It may only be in one spot here or there in the kidney. So when we do that simple kidney biopsy, we may not sample those areas that are scarred. But what we can do is just give our best guess. So if we don't see any areas of scarring, we say that that's consistent with minimal change disease and can confirm that that diagnosis. However, some children who have a diagnosis at first of minimal change disease and a biopsy with minimal change disease do go on to develop more of a scarring or FSGS type picture later on. So if you have minimal change at first, it's unfortunately possible that may change over time.
Great, thank you for that clarification. Angel Mary is asking, is it standard to look for interstitial fibrosis when they do a kidney biopsy?
Yes, so that's a standard part of any kidney biopsy, and the pathologist usually will report out in their report. Many will report a percentage, or they'll just say no. no interstitial fibrosis. So patients with minimal change, we would expect they would have no interstitial fibrosis, kind of by definition. Since it's minimal change, there should be no changes there. But patients with FSGS will be kind of all across the board.
Great. And then Cassie is asking, can you define partial remission in terms of protein levels in the urine?
Yeah, so there's no standard definition of partial remission. It's defined differently in different trials. So many people will define it as cutting the proteinuria in half. So if you start with a protein to creatinine ratio of 5, cutting it down to 2.5 would be considered a partial remission. And that's probably the most standard type of definition there.
Okay. And then Kara has asked, what is your experience with children outgrowing minimal change disease?
Yeah, so we do expect that kids with minimal change disease are going to outgrow it. And that just means that at some point, they're not going to have relapses anymore. However, they always remain at risk of having relapses. I will say the longest I've seen somebody go without a relapse is 16 years. So somebody who had minimal change as a small child, had a lot of relapses, and then by the age of 5, they didn't have any relapses anymore, came off all of their medicines. And then later on, when they were in their early 20s, kind of called me again and said, hey, I think I'm having a relapse again. What's going on? And yep, it's just the minimal change back again. So many kids will grow out of it. I always tell families that every relapse can be your last relapse. I just can't predict which one that's going to be. So once we find if patients are on treatment for on some kind of maintenance treatment to keep them in remission, I will usually keep that medication on until they've been 2 years relapse free. And then once they're 2 years relapse free, try to start to take that medicine away and see if they have relapses. And sometimes they relapse and we go back to where we were before. But I like to give kids kind of a chance to be able to come off of medications if they can.
Absolutely. Yeah, that's great. Jennifer has a question. Is there any treatments once you know your child has genetic FSGS?
Yeah, another great question. So for some of the very rare types, the mutations I mentioned in the study, their coenzyme Q can be used as a treatment, but those are probably, one patient in 100,000 is going to be that type of patient. ACE inhibitors are very important to treat the genetic forms. They're not a cure-all, but as much ACE inhibition as you can really takes the pressure off of that glomerular filtration barrier. So that's the main way that drug is working and can help to protect the kidney. And then there's a new class of drugs that's out called SGLT2 inhibitors. And these are medications that were initially devised for diabetes. But what we found in adults with chronic kidney disease is that they not only protect the heart, they also protect the kidney in a number of different ways. And we're finding that those are going to be really standard of care for adults with chronic kidney disease. We don't have any studies in children with chronic kidney disease, but I think that is going to be one of the things that we're going to be able to add, hopefully here in the next few years, as another general treatment. So, I'm guessing the standard of care is going to be patients will need, they'll be on an ACE inhibitor, they'll be on the SGLT2 inhibitors, and that combination in a patient with genetic kidney disease is going to help protect their kidney. Now, of course, we would love to have a cure for and more specific treatments for each of these genetic kidney diseases. And a lot of the companies are working on those very specific, particularly Goldfinch is looking at a couple very specific disorders.
Yeah, absolutely. More precision medicine, right? Jessica has a question. What is your experience with recurring FSGS after transplant?
Yeah, I would say I have a terrible experience with recurring FSGS after transplant. So this is really the dreaded complication. You've been fighting with this disease for years, usually at that point, and then you get a transplant, and it's supposed to be a new beginning, and it's supposed to be the new start, and then the disease comes back, and you're right exactly where you started before, trying to figure out what to use to treat it. So many kids will respond to plasmapheresis, which is a treatment like that lipopheresis, but it just removes the plasma from your body. But many kids don't respond to that either. So Here at the University of Minnesota, we are running a clinical trial that was sponsored actually by the Department of Defense, looking at treatment with rituximab before the transplant to see if that can help to prevent the recurrent FSGS from happening. So we're enrolling in that study now, because once the disease recurs, it's hard to treat. But if we can figure out ways to prevent it from occurring in the first place, that's our goal.
Janet is asking a question. Can you speak about, I'm gonna butcher this name, Gaziva versus rituximab? She's heard that kids are having less reactions, but not much is known about dosing.
Yeah, so I'm not familiar with that brand name, but I'm guessing what it is the humanized rituximab. So rituximab is a drug that's made from there's some mouse antibodies that are in the rituximab. So some of the allergic reactions that happen are really related to those mouse antibodies that people react to. So the other version is a humanized version. So it's all human antibody, and some patients do have fewer reactions to that. It does seem a little bit better tolerated than the rituximab. But you're right, we don't have the big studies like I showed you where we treat 100 patients with rituximab and see how they do long term. So we don't have as much information about how to use that, but it is another option if you have allergic reactions to the rituximab or have concerns about that.
I'm going to ask another question before we get on to around rituximab. We get a lot of questions from patients around insurance appeals. Can you talk to us a little bit about what your role is in that, and then what can the patient or patient parent do to assist with that effort as well?
Yeah, that's kind of the bane of our existence in pediatric nephrology is trying to get drug companies to get insurance companies to approve these medications. So one of the things that's really important is advocacy from the NephCure organization and from parents to their state legislators, to their national legislators, in order to make sure that the patient doctor decision making is not given to the insurance companies. So making sure that that those decisions aren't being made by the insurance companies, that they're being made by your doctor. And there are some bills that are up in some states trying to protect that. But what we generally first have to do, the main reason to get an insurance denial is if there's not a label indication. So if the FDA hasn't approved that medication for that indication, then we won't get it approved. And rituximab has not been approved for nephrotic syndrome of any type. So we cannot, it's not an easy one. So we have to send in studies that support our wanting to use it. And I have a stock letter that I've put together that lists all the reasons why I should be able to treat, why I want to use rituximab to treat my patient. But some insurance is really strict. It's not on their list of drugs, and no matter what you tell them or say or do, they're not going to approve it. And a lot of these medications are really prohibitively expensive. So some of the drug companies have patient access programs where they will provide the medication for free or reduce costs. So we've used that in a number of occasions. So really just look, if it doesn't get approved, which happens, trying another option. And then if that second option doesn't work, sometimes going back to the company to say, see, I failed this one, and now we have to try this other one again. But trust me, your doctors work very hard. I am not somebody who loses my temper very often. I'm a pretty calm, quiet person. And I think the only times I've really lost it in my career have been on the phone with insurance companies.
I think as parents, I think that we have had those matches with insurance companies as well. So I know that you work hard, and thank you for that. Cassie has a question. She says, it's interesting that it takes up to 6 months for tacrolimus to reach remission. Is it standard of care to add a second line treatment without waiting the 6 months, say after 4 weeks and adding CellCept?
My practice is really to give that full 6 months to let really know if this drug is working or not, because that's a very important distinction for me in what I'm going to treat going forward. So if kids really are not responding at all to the tacrolimus, then there aren't a lot of options to use next. So I want to know if they need it. And we don't have a lot of good data on adding mycophenolate to tacrolimus in that setting. Many people do it, and in many kids it helps keep them in remission, but we just don't have a lot of information to know when is the right time to add that, and how much should we be adding, things like that.
Kristen asked a question: when on CellCept and a child experiences a relapse and has to go back on steroids, are there advantages, or why would you stay on CellCept during the relapse?
Yeah, good question. So the CellCept it takes a little bit of time to build up in the body. So having that constant level of CellCept, we think is pretty important. So I do treat patients with both the CellCept and the prednisone during the relapse. The CellCept, sometimes the question is, if you're having CellCept or if you're having relapses while you're on the CellCept, why should you keep taking that at all if it's not keeping you in remission? And for some kids, it's just enough to lower the amount of relapses. So maybe they were having 5 relapses a year before, and now they're only having 1 relapse. Only having 1 relapse, but that can sometimes be an advantage.
Is there any correlation with dairy or gluten restriction improving proteinuria?
Yeah, that's a great question. So as far as relapses go, every kid is really individual in what triggers their relapses. So for some, it tends to be allergies. For others, it tends to be colds in the winter. Others, it seems to be certain foods. And some families have really noticed a sensitivity to gluten in triggering relapses. Others, no change at all. So this is an area that's really being actively looked at, because it is, something that we can control, and we can control what kids are eating. So there are a number of groups that are doing studies and clinical trials looking at kids with nephrotic syndrome and treating them with gluten-free diets and seeing if that can keep them in remission. I recommend to families who have kids who are having frequent relapses to really kind of keep a diary of when their kids are having relapses. And many families can come up with something that they think is a trigger, and then we can work on trying to eliminate that and seeing if it makes any difference.
Yeah, absolutely. This next question might be a little hard to answer, but overall, what do you think, or what is your opinion, I guess, on the overall length of the life of the kidney when someone is diagnosed with FSGS?
Yeah, so my goal is to have that kidney last as long as possible, in whatever way I can, by finding these medications, because we know that you are better off, even if your kidney is not working very well, you're better off with that kidney than you are with a kidney transplant. So keeping your native kidney healthy as long as you can is really the most important thing that we can.
Yeah, there's a couple questions in the chat I'm going to move over to. Lucille has asked, do you have any thoughts on using low dose MMF to prevent interstitial nephritis? Our daughter achieved remission using a combination of Prograf and MMF, and we don't know when to wean off one of the meds. She's been in remission for the last 2 years now.
Yeah, great question. So we don't have any data to suggest that MMF would help to prevent that interstitial fibrosis. We do know that Prograf, or that tacrolimus, that's where the scarring happens from tacrolimus, that's that interstitial fibrosis that happens when patients are on that. So using the lowest possible dose of tacrolimus would be helpful. So if I had to choose one out of those 2 drugs to reduce the dose on, it would be the tacrolimus first, to try to get that dose as low as possible. And sometimes by adding that MMF or mycophenolate, that allows you to be able to reduce that tacrolimus as low as you can.
All right, and then Janaea has asked, are there any studies with any of the meds you talked about and the COVID-19 vaccine?
Good question. So a lot of the studies are in the transplant population. So many patients with transplant are on mycophenolate and tacrolimus. And it seems that mycophenolate in particular, patients who are on that are not responding as well to the vaccine. So that's a concern. And then patients who have received rituximab within the past 3 to 6 months are also not responding as well. So it's really a challenge in patients with nephrotic syndrome who are on those medications, because the risk of stopping the drug to give the vaccine is real. We all know that if we try to stop these medications, very easy to have a relapse, and then you have a child who's now immune suppressed with steroids or with other medications, or because of the nephrotic syndrome itself, who's at high risk. So right now the recommendations are not to stop any immune suppression, but to kind of give the vaccine through the immune suppression that they're currently on. And then if they're on rituximab, to wait, at least 3 months, wait kind of as long as you can after that rituximab infusion to give the COVID vaccine, and then to try to wait at least 2 weeks after that second dose of the COVID vaccine. So to try to time it right before your next dose if you're getting a series of doses.
Yeah, I have to say, we just had an appointment with our specialist, and there was some guidelines on skip this dose and then wait a week. Anyways, it was but it was very helpful, because my son's 12, and I sure wanted him to get the risk. I mean, I think the benefits definitely outweigh the risks too. So,
and we think that even if you don't get full immunity from that vaccine, it's still better than nothing, and there's still benefits to having that immunity.
Yeah, absolutely. Claudia asked, do doctors often keep kids on medication for many years in remission to reduce the risk of relapse? My daughter's been on tacrolimus for 4 years, but has steroid-resistant nephrotic syndrome. I'd like to take her off, but not sure of the risk versus benefit.
Yeah, that's a great question, and it's something that we really struggle with, because we know that if you had steroid-resistant nephrotic syndrome and FSGS on biopsy, it's likely that you will need a medication long-term to keep you in remission, and that if we try to take that away, that you will have a relapse, and it may be hard or impossible to put you back in remission with that same drug. So nephrologists are always a little bit hesitant to try to stop that medication if it's been working well for you or your child. And but this is a decision that's made between all of you, parents, child, and we always don't want to be using medicines if you don't need. And there are patients who, maybe they had terrible steroid-resistant disease before, but you are able to get them off of medication at times. So understanding the risks, which it sounds like you do pretty well, if you come off the drug, you may have a relapse, and trying to reduce that dose as much as you can and just seeing what happens. If that's a risk you're willing to take, then that's good. Understanding the time in your child's life when you do that is also important. So that's not something you're going to want to do a month before they start high school, because that's, it's an important time for them. They got a lot going on. It's never really a great time to have a relapse, but you want to make sure it's not, you're not stopping the medicine a month before you're going to Disney World, or, I've had these discussions with all kinds of families, when is the right time to do it?
Yeah, absolutely. That's a great thing to think about as well. I appreciate that perspective. So our time is ended. I want to thank you once again, Dr. Rheault, for joining us today and providing great insight and answering all of these questions. I do want to once again, thank our sponsors who have helped sponsor this entire program today, and that we're moving into a quick break from 2:40 Eastern time to 2:50 Eastern time. So you have about 9 minutes, because I'm Central Time, so it's 1:41 here. You have about 9 minutes. I would encourage you to go to your regional roundtable in 9 minutes, 2:50 or whatever time it is in your time zone, because you can meet your regional leader and you can meet some of the other people in your area and talk about some goals and objectives maybe for this next year. So You can log into your regional roundtable from the lobby. So you'll, in Philanthropy Refined, it's that green sidebar. So go back to the lobby, and under my sessions, you should be able to see your particular regional roundtable. So see you soon. Thank you so much, Dr. Rheault.
Thank you.
Thanks.